Welcome to the Science Her Way podcast. I'm Kelly Pritchett.
I'm Anna Freire.
And I'm Robert Pritchett.
We are the co-hosts of the Science Her Way podcast. Welcome to a journey that celebrates innovation, empowerment, and science. We are thrilled to introduce you to Science Her Way, a podcast to explore the wonders of health and sports sciences. So fasten your seatbelts because we're embarking on a thrilling expedition through the world of health and sports sciences, driven by the relentless force of curiosity. Stay tuned for more engaging conversations, remarkable stories, and a celebration of Science Her Way. Welcome to another episode of Science Her Way. I'm Kelly Pritchett.
And I'm Robert Pritchett.
And I'm Anna Freire. Today we are interviewing one of our colleagues and the Department Chair of Health Science here at Central Washington University, Dr. Tishra Beeson. Welcome to Science Her Way.
Thank you so much. Thanks for having me.
So Tishra, as we kick off Science Her Way, we want our listeners to get to know you. What sparked your passion for academia and research, especially the public health field, and how did you end up on your scientific journey?
So I guess for anybody who doesn't know me, I should share that I am a public health professional. That's my background, and that's what I studied through graduate school. But my story starts, I guess, a little bit before then. My family is actually from Colombia, from South America. My mom is a first-generation immigrant to the United States, and my grandfather was a rural physician in Colombia for many years before moving to the U.S., and this was in the 1960s, back when in the U.S., foreign medical graduates were not really recognized for their medical licensure in the same way that they are today. And so my grandfather actually had to go back and do a residency over again in the U.S. in order to be able to practice. So he did his second residency in anesthesiology, became the chief of anesthesia at a VA medical center in Kansas until his retirement, and had a really long and kind of illustrious career as an anesthesiologist after learning English as his second language. So I think about that story, and that kind of was the inspiration for me. I thought for sure I was going to follow in his footsteps and I was going to be a doctor and, I don't know, chief of anesthesia someday or whatever. But I thought that that was the only way that you could have a health career, is that you could be a physician or maybe a nurse or a pharmacist. But I didn't really know that there were other pathways and other opportunities that you could help people live healthy lives. So thinking about my undergraduate career, I was a pre-med biology major, right? That was kind of the traditional way that I thought I was going to follow in this career path. And so something happened around my junior year in college when I got to study abroad. And I actually chose to study abroad in Colombia. It was the first time that I really got to go on this heritage-seeking expedition, is what I call it, right? Like to really get to know my roots and my family and my history. And so I just enrolled as a student there. I just went abroad. I enrolled as a student, started taking classes. I worked as a medical translator in the hospital system. And what I saw was just that the medical system, even though, Colombia was a developing country, it was a very good, system in terms of delivering health care. The problem was that not everybody could access it, and that there were conditions in people's social environment and their physical environment and what they were exposed to that was impacting their health, sometimes even more than the medical care that they could receive. So I was really interested in these kinds of things, what I now know to be social determinants of health, and the things that I know as I've studied and have kind of become engaged in this work are all those things in our environment that affect our lives, our health, and our well-being are just as important as our behavior, just as important as the care that we get, all these things that are just critical to individual and community health. And that really is the nexus of what public health is. It's taking into account all of those things in someone's environment, where they live, where they work, where they play, where they raise their families, and knowing that all of those environments, systems, policies that they're exposed to have an impact on our health. So that's what got me excited about public health, and I came back to the U.S., and I went to grad school, and I got a Master of Public Health, and I focused on health disparities, which was really about looking at equity and how certain populations might be more exposed to some of those harmful conditions than others, and how can we address those inequities. And then, I continued because I just got really excited about what I was studying and the work that I was doing, and I was fortunate enough to be given a fellowship, a Gates Millennium Scholarship Program, which is the Gates Foundation, which funded all the way through my doctoral program in certain areas, and they're really passionate about public health, and that was one. So I continued to pursue that, and I got a doctorate in public health, and as I mentioned, I was really interested in policy. So I went to Washington, D.C., and I got my doctorate in public health at the George Washington University, right during the time when our country was undergoing huge national health reform. And so I was there as this major federal policy was taking place and changing the entire landscape of what we know in the U.S. in terms of health and healthcare today. So that's it. And that's kind of where I am now, and it's really made me excited and passionate about the work that I do.
Well, that's a pretty exciting journey. I think we do have a lot of students that are still kind of figuring out their path. Could you tell us a little bit more about what are the possibilities for a professional in public health? What are career path exactly, and what are the options? What can they do with that degree, for example?
Yeah, so I mean, the beauty of public health is that it's really intended to be multidisciplinary, and there are so many different places and settings and populations that you can serve as somebody who has a public health training and background. So I mentioned, my work is in policy and in programming, but I have colleagues who are in epidemiology, who are looking at disease trends and patterns and investigating, variables that might be associated with certain outcomes that are changing. And of course, everybody during the global pandemic, COVID-19, has heard about an epidemiologist now, right? But that is a traditional public health professional pathway. There are folks who work in environmental health, right, who are looking into our water systems or our air quality. There are folks who work in social and behavioral health and looking at how people change their behavior is related to, what their goals for their own health are. So there's so many different ways that you can impact an individual or a community's health by working in public health, because it really is probably one of those disciplines that has a place in every setting and with every population. We have a saying in our program where we talk about public health is central to all people in all places at all times, right? Because that is, if anybody has lived the last few years during this pandemic, we've realized how critical those things are to a functional society.
And we can hear that research is a really big part of public health, right? What did inspire you to pursue a more academic path, a research path? What was the things in your background that really sparked your eyes into research?
Yeah, so I mean, for me, research informed policy, which I would say kind of my interests lie at the intersection of research and policy, and how important policy decisions, when we think about whether it's at a local level, a state level, or a federal or international level, the worst thing is when we see a policy that you think, where is the data behind this, right? Yeah. And who is making these decisions if it's not grounded in the science? So for me, I find real fulfillment in the work that I do when my research is applied and where it has real implications for making decisions that are going to benefit or maybe limit harm for populations. So that's where my interest and my skill set is, really at that intersection of research and policy.
So can you highlight maybe one specific project or experience through your academic path that really ignited this passion through your master's and through your doctorate?
Yeah, I can actually talk about one of my areas of interest and how I think, some of the experiences that I've had have led me here today. And so I consider myself a maternal and child health researcher. That's kind of the area of interest where I've spent a lot of my work and my research portfolios on maternal and child populations. And we know in the United States that we have a not very good situation when it comes to the health of birthing persons and of children in the U.S. We have the highest rate of maternal mortality among all high-income countries, and the only one that has been increasing over the last decade. And we know that our infant mortality rates are pretty dismal too, right, when we look at other high-income countries.
Can I ask, like, why is that? I'm kind of surprised with that data. I didn't know that.
Yeah, so, if you look deeper, we have really big disparities, really big gaps between, racial and ethnic minorities. And so I think sometimes when we look at the data and we parse that out, we see there are some really severe issues that need to be addressed there. A lot of those are back to our social determinants of health, right? And a lot of things are related to the way that we allocate resources in the United States. We tend to overspend on highly specialized, highly technical, and highly expensive care, and we don't do enough in terms of prevention and some of those early intervention things that we know are going to keep populations healthy. So if you look at like global data and you look at comparative health policy, comparing certain countries, we can see that the countries that have spent more resources on prenatal and prevention and, early intervention care for women have much better outcomes. The countries that spend more on some of these later tertiary care interventions don't have as good of outcomes. And so it really has a lot to do with how we allocate our resources in the U.S. And unfortunately, relative to what we spend, we do not get the best outcomes for these populations. So for me, it's really an area that is like an imperative in terms of a policy priority. It's an area in the United States, I think even one death that could have been preventable is a tragedy, right?
Yeah.
And so we should think about how can we shift our policies, our systems, our programming, how can we allocate federal and state resources and funding to better address these gaps, to reduce those risks, and to prevent them altogether.
And how did COVID-19 affect this paradigm?
Yeah, so that's one of the studies that I am currently working on. Not surprisingly, the COVID-19 pandemic exposed a lot of our current public health issues and made us pay a little bit more attention to them, right? It's become a lightning rod for some of the issues. Even beyond infectious disease and global pandemics, we're now seeing some of these issues exposed in a different way. So one of the things that I was most interested in investigating was how the COVID-19 pandemic was going to affect pregnant people and families and infants. So a colleague and I, Dr. Amy Claridge here at CWU in the Child Development and Family Sciences Department, we initiated a cohort study of women who gave birth during the global pandemic, and to really understand, what was their experience, what were some factors that were really unique at that time that could have affected them differently than, were they going through a pregnancy at any other time. We didn't really know, right? It was early in the pandemic. We didn't really know what was going to happen. And so we really were just collecting as much data and information as women were able and willing to tell us about their experiences. So we did some online surveys. We conducted individual interviews. And we followed them for a period of now, we're going on almost 3 years that we followed this cohort, and to try to see a little bit more about, how the pandemic has impacted them.
Can you, one of the things that I remember about COVID-19 and maybe individuals who are pregnant was the fact that they may not be able to have guests in the room and things like that. I mean, were these some of the common concerns that you heard?
Yeah, so you might have even read some headlines, right, about like people going through a birthing experience and being completely alone at the time. And those were things that we wanted to learn more about and to understand what those patterns were looking like. So in terms of our study, what we've published is we know that nearly all of the women in our study reported a major disruption to their prenatal care experience or to their birth experience. So things like, I couldn't bring my spouse or my children to my prenatal appointments, or I had to skip my ultrasound, or I had really high blood pressure, but nobody caught it in time because I wasn't able to get care. Or, people who had to deliver their child wearing a mask or without, their partner or their spouse in the room. Or a lot of women who chose, I don't want to give birth in a hospital because I don't know what that experience is going to be like with all these new restrictions. And so they had a pretty dramatic change in the experience that they were expecting to have, as many of them were, pregnant before the pandemic and then going into this really major change. So all of this change coupled with, stay-at-home orders, if you all remember, right? We had in the early days of the pandemic, we were all told to stay home. There's this just general fear of the unknown, not knowing what the virus was going to be doing to pregnant women or to their fetus, right? All of those things were increased stressors and elevated risk for mental health conditions. And so what we found is that over half the women in our study had depressive symptoms consistent with clinical depression during the time of our study. And we're talking about over half of women. That is considerably higher than what we would expect in the general population, and certainly in normal times, we would not expect half of pregnant women to have these clinical risk indicators. So we followed up with participants in the weeks after birth, and what we found was that we had some resolution of some of those depressive symptoms. So from what we could tell and what we can characterize, really high swell of risks prenatally. They go through maybe this birth experience, maybe it was dramatically different, but maybe it was better than they were expecting. And so there was some resolution and at least the average depressive symptoms that we saw. But then as we followed them later in postpartum, we saw a return of much higher rates of depression. And some of that could simply be the nature of the pandemic, right? Things got better, things got worse, right? We saw this kind of ups and downs and ebbs and flow in what was happening socially, in the conditions. But it was a really unique, almost like a natural experiment for us to follow this cohort of women and all of the things that they were experiencing and be able to give voice to those experiences.
And how many subjects or participants did you have in the study, and how diverse was their demographic?
Yeah, it's a great question. So we started, as you can imagine, there was very high interest at the very beginning, right? I think we had like 1,500 or 2,000 participants in that first wave was what we called it. And over time, as we know, typically happens when we're recruiting subjects or when we're following people, we do have some attrition, right? So we didn't get necessarily that huge interest in the later stages of our study. But I think in total across, all of the waves of our study, we have complete data for about 200 women on following them for about 3 years.
That's amazing. Wow. What states are they in, or are they?
Yeah, so it was a national study. We recruited folks from essentially anybody who we could get to participate from all different states. Now, I will say predominantly the sample is less diverse than we would like in terms of race, ethnicities, fairly highly educated. And those were things that we've actually found to be pretty consistent in a lot of online survey research that we're seeing being published out of the pandemic, that the folks who were able to participate in surveys or had either the time or the interest to participate in these things were more highly resourced. And that kind of makes sense when you think about, who has the time and the energy to participate in surveys at a time when there are some really complex things happening in the social environment.
And what are the lessons you think we can take from the study when we are thinking about maybe preparing for future pandemics or similar scenarios, or even beyond COVID-19? What do you think it's the main lessons that and adjustments that we might have to do for future actions?
Yeah, so I think about two major takeaways from my involvement in this study, and you've heard me talk that a lot of my interest is around the intersection of research and policy. So I often focus on what are the policy implications of our work and the results of our studies. So first, if you don't know, there are a lot of clinical guidelines around the screening for depression among pregnant and postpartum people. But it's a little bit confusing depending on which professional association is giving that guidance, whether you're talking to pediatricians versus OBGYNs versus, some of the patient advocacy organizations. There's not a lot of consistency in those guidelines. And so depending on, who your professional association is, you might have a different standard in terms of, when pregnant and postpartum people are going to be screened. So the complexity of the pandemic situation and how that affected potentially this risk profile for these women is making it even more complicated. And so essentially what we frequently say as we think about the dissemination of our work is trying to provide more regular screening and most importantly, connections or referrals to clinical care and treatment for women who might need that care. We also found that very few women in our study were actually able to go back and get postpartum care. And I think nationally that's consistent with what we know in the evidence base. Only about half of women get one postpartum visit at all. So the opportunities to get referrals or to get screening and to get treatment are even more limited when you think about this population. So thinking about more regular screening, more referrals, more integrated care so that, we don't have people falling through the cracks, people who really need treatment and aren't able to get it for whatever reason. The second takeaway that I'm thinking about and that I am advocating for oftentimes when I think about my work is so we know that there's a higher risk for maternal depression in this population, but we're also seeing as we follow them into their third year that risk is persisting beyond those first 8, 10, or 12 weeks of postpartum. It's persisting into the first year, into the second year, and into the third year. And there hasn't yet been any federal regulation, especially for Medicaid, which is the largest public payer in the United States for coverage. There hasn't been a federal regulation that guarantees care for pregnant women up to 12 months postpartum. It's left to the states. And there are some states that are, very clearly committed to investing in maternal and child health, and so they have expanded Medicaid and cover women up to 12 months. But in some states, that's only 60 days of coverage. That's the minimum that states are expected to provide coverage for. So you can imagine if you're a pregnant person and you've just given birth and you have needs beyond those 60 days, you might not have coverage for those medical needs. So thinking about expanding Medicaid coverage, expanding insurance coverage so that people have a guarantee of at least access to care if and when they need it, and making sure that that's true for all women up to 12 months. But again, our study is saying potentially beyond that.
Yeah. I mean, I know personally that it was such a tough time, especially with my first child, and I do remember going to my 6-week appointment and just breaking down in tears and as to why I figured out, what worked and helped me with those symptoms. For me, it was just having some time each day where I could get outside, and that really improved, those symptoms. So,
yeah, and it's such an individualized, journey for someone to feel like they're completely alone, or to feel like they aren't going to get those needs met because they don't have coverage, or they don't have a provider, or they're dealing with all of these other stressors in their life, and it's also in the middle of this pandemic. That's a complicated situation to be in. So when we're thinking about really caring for people when they need it most, the basic thing that we can do, at least in my opinion, is guarantee that at least their care will be covered.
And what are the future steps now for the research? What is ahead?
Yeah, so we're, as I mentioned, we're kind of into this third year of data collection and analysis, and kind of looking at some of what we're now calling persistent postpartum depression risk. And if we're seeing some of those risk factors persisting into that third year, that those findings will be really important to be able to share, because there aren't that many studies that are able to follow a cohort for that long, and especially not in the conditions that we were seeing present during the pandemic. So hopefully we'll have some results to share soon.
And so, Tishra, what are some of those risk factors?
So what we tend to see is, not surprisingly, this is true in the literature before the pandemic. So our study was not really novel in that way, but it certainly confirmed what we know to be true in terms of risk factors are things like low income status, people who have experienced violence or experienced intimate partner violence certainly have a differential risk. Individuals who have had a prior history of a mental health condition. So all of those things, and then again, just kind of regular everyday stress. We think of risk as compounded, right? So all of those things kind of compound the potential risk factors that would affect someone's mental health status.
And do you think that someone who's a full-time working mom who experiences that for the first time, do you feel like that is a risk factor? Like someone who's, they're in a corporate job, maybe high power, and then all of a sudden they go home, and it's like, what do I do? It's completely new. And
yeah, absolutely. And we tend to see, there have been some studies that look at like the timing of when depressive symptoms, tend to be really bad. And we see sometimes, if postpartum people are going back to work, and sometimes just that big life transition can present in a way that's really stressful, and it is difficult for someone to navigate.
But I would imagine for high-powered, career-driven females, that time at home, feeling almost unoccupied from their career or their profession, and they just have this infant, and dealing with this infant must also spark these depressive symptoms.
Yeah, any life change, right, that we all have,
Yeah.
and you're seeing, different changes in your lifestyle and different things that you're exposed to. But also, the other thing is that we haven't talked much about yet is the protective factors, right? So we look at both risk factors, but then we also look at things that actually protect you from those risks. So things like having a really supportive family structure, peer supports, getting care when you need it, intervention and treatment, having resources available at your fingertips, having a higher educational status that you can, navigate information and seek care when you need it. Those are all things that are protective factors. And so when we think about, those differential risks, but also differential protective factors, and where can we improve or enhance those protective factors for everyone, so that we see maybe some minimized risk disparities.
And is there any limitations on the research that you'd like to highlight, or maybe give advice for future researchers in that area?
Yeah, so I think this is a great question, and something I've been thinking about more as I think about my own academic and researcher trajectory. Is I remember early on in my career, you all probably have had similar moments where you would take reviewers' comments so personally, right? And you especially reviewer two, right?
Yeah, reviewer two.
I would remember thinking, did they even read the same paper that I wrote? What is happening here? And I would take it so personally. And, obviously over time, you grow accustomed to good criticism. And actually, I look forward to it now, because I think, my gosh, this is making me a better scholar. It's making me think differently. It's making me think about the application of my work and how this is going to impact people who read it. Because it's one thing if we write it a certain way, but if that's not the way that it comes across in our papers or in our publications, then there is some work for us to do on that. And so I have really become a real fan and advocate for people to be very transparent about their study limitations and the biases that are inherent in every research design. And, I think it's a sign of a great researcher to be able to communicate and articulate that, to defend it when you've been very purposeful about your design or methodology, and to acknowledge and embrace where those limitations are and where you can make inferences, and also where you can't make inferences and conclusions about your work, and to be really transparent about that. So in terms of this study, certainly the sampling, when we think about trying to get as large of a sample as possible, there's definitely some bias there, because we really opened it up to anybody, and they self-selected, they met the criteria, and we enrolled them in the study. We also had some attrition problems, as I mentioned earlier, right, where lots of folks participated at the beginning, but fewer and fewer toward the end. So there's some selection bias there. And then our sample is not as diverse as we would like it to be. So there's only so much we can say and can generalize about that.
There's some great lessons there from a study design standpoint, and reviewers, I think we can all relate to that. Fresh out of a PhD, I might have been crying about the comments, but it's definitely some good wisdom there. So kind of skipping gears a little bit, you've recently stepped into a leadership role as department head for health sciences. Can you talk a little bit about that, transition, and maybe some challenges, if you're willing to share those with us?
Yeah. So no, I feel very lucky to be in a department that is as supportive and, really visionary. I think I'm having the best time really thinking about and working with all of you in carving out what our new future of health sciences is. We have our new building on campus, really great opportunities for partnerships and collaborations, both in the classroom and in our research. So for me, I think my role as department chair a lot of times is to get out of the way and let faculty and students pursue those innovations and pursue those really exciting research plans, and the best role that I can play is to support you all and to find, ways to bring in new resources, to bring people together that I know or that you all know, and engage them in some really transformational research and learning both in and out of the classroom. So that's kind of where I see my role, for better or for worse.
Yeah, I think it definitely takes a special person, and you maybe have to have thick skin and a lot of patience.
Yeah,
so,
thank you to the reviewer too for that.
So it's really awesome to see such an amazing female leadership for our health science department. So thank you for that.
That's very kind.
What's the landscape of female department heads across a campus like Central Washington, which is a regional school?
Yeah, that's a great question. I don't know the data off the top of my head, but I can definitely look around the room when I'm in meetings with my colleagues, and I would say women are still in the minority when it comes to leadership in higher education, and that landscape could be changing. I think it is definitely motivation for me and others to stay in the game, right? And to show up and to be present and to bring our whole selves and our whole identities to the table. I think that's something that women do really well. I'm pretty unapologetic that I'm a parent. I'm a member of my family and my community, and I have hobbies and things that I enjoy in my life, and those are very much a part of me, just like my work is a part of me, and just like my professional commitments are a part of me. And being that whole identity and being seen for that whole identity is something that's important to me, and I hope that other people also value that. But the only thing I can do and I can control is to show up and be that full self.
What about advice, Tishra? So we have a big audience on students, general population that maybe are still figuring out their future steps. So in your perspective as faculty, researcher, public health professional, what is your main advice for those individuals?
Yeah, so I think of two things. The first is that I would just encourage students, and if I could go back and tell myself this, I would. And that's just to be open to new opportunities. If a door opens to you, there's no reason that you couldn't walk through it, look around, and then decide, no, this is not for me, and walk back out, right? But you won't know until you take that first step. You won't know until you try. And I've always kind of found that sense of safety in saying, this decision isn't forever if I don't want it to be. And sometimes I do find something that you fall in love with and you realize, I want to do this forever. Right. But there are other times where you try and you realize this isn't forever, and that's okay too. So being open to opportunities and evaluating periodically throughout your life and prioritizing, I think is a skill set that if I could go back and tell my younger self about, I would encourage that. And then the other thing that I think about is seek the company of the people that you want to be like. I've always found it really daunting, when people would say like, oh, well, who's your mentor? And I never went to someone and was like, will you be my mentor? Right? That wasn't a conversation, but I found myself drawn to and in the company of people that I just really admired or that I felt inspired by. And I would seek them out informally. And that was my mentoring, right? Just by being around the people that inspire you. And so it's one of the reasons I've stayed connected to my research and even teaching as I've been moving into administrative leadership. I don't want to lose those connections, and I don't want to lose the presence that I have in the classroom or in my research. As I move into some of these leadership roles, I want to hold space and be present for my students, for my colleagues, and for the people that I serve.
Fantastic.
That's great. Yeah, thank you so much, Tishra. We really appreciate your words of wisdom and sharing your career path with us. But To our listeners, buckle up for an exciting journey ahead. Science Her Way is here to spark curiosity, share knowledge, and make science relatable.
Stay tuned for more captivating conversations, groundbreaking research, and a few surprises along the way.